in a talk. I put this in a talk, and actually this is not all I have. I have more than that, but for the time constraints, and I just put the best or the most of the important portions of common misses and the in relation with the search pattern in neuroradiology. اول حاجه هنبدا بيها ال CT spine trauma. So we should consider points needed to review on each specific plane. So using the planes like sagittal plane, we should look for the disc spaces, disc space widening, facet joint widening, jump perched facet, especially the cervical spine, large disc protrusion. In CT, definitely we're not able to see like the disc protrusion as good as the MRI, but at least we can determine if there is a large one. Epidural hemorrhage, prevertebral hematoma, pars break, especially the lumbar spine, spinous process fracture, acute compression, fracture and the step off of the upper endoplate or mostly upper endoplates. So we should just consider all this in our search pattern, looking at the sagittal reformats in bone window. In the axial run, we should look carefully for the lamina, especially lamina are thin actually in the cervical spine, so they're easy to be missed. Look for reverse Hamburger bun sign, which is like indicates unilateral facet dislocation secondary to rotational injury, fracture of an endoplate. الحقيقة sometimes acute endoplate fracture, we might not be able to carefully see or like accurately see in the sagittal, but sometimes the axial can show a fracture line at the endoplate level. Can be a confirmatory look. Transverse process fracture, sacral iliac fracture, insufficiency fracture of the sacrum, which is a common miss in like elderly people, especially CT and MRI. We will have tendency not to look at the end of the run or like edge of the film by the old definition. Sacroiliac joint widening, also easy to miss. Again, in the axial plane, T-spine, sometimes it's challenging. You may need to more than one run to scan each component in the axial. Endoplate fractures, coronal can be helpful to decide whether this fracture is acute or chronic. Definitely, if you see a little buckling rather than fracture line, then it's more of like chronic or subacute. Lumbar spine pars fracture, partially visualized sacrum, foramina transversaria in the axial and the cervical spine, and vertebral body injury. You may request CT angiogram based on seeing a little bit of like fracture line in the axial run, and the fracture first strip. Common misses again. Radiologists should be aware of an easy to miss findings such as ADI, atlantodense interval, or Bayesian dense interval, occipital condyle fracture. Usually, I look at the coronal plane specifically to see if there is a chip fracture at the occipital condyle. Lateral mass of C1, C1, C2, lateral mass distance in the pediatric age group. We look at the pediatric dense clival distance. There is this article talking about the Bayesian cartilaginous dense interval, which is like important to just make sure this distance is not widened, because in pediatric age group there is large part of this is cartilaginous. The visualized rib fracture lines through the endoplates checks the axials. Could be seen only as clue for fracture. Here we have an example for a perched facet, locked facet, as you see here. This facet joint jumped and locked, so it can't return back to like similar to the above facet joint. So this is an easy to miss. If you see like Enterothesis and just okay, there's enterothesis. You know if if it's acute or chronic, if it's traumatic or not non-traumatic. Go back, like scroll in the sagittal plane just to look for this sign of locked facet. And here is a jumped facet, as you see at 5-6. In this case, basically, I looked at the T-spine sagittal view on the CT, and I noticed that a little bit of minimal compression deformities at multiple levels. And when they did the MRI, it shows like multiple upper endoplate edemas uh, concerning for subtle upper endoplate fracture at multiple levels. As you see here, there is a little bit of step off. Okay. Again, here, rib fracture, easy to miss. The end of the run, the lowest cut, there is a line of fracture. Here, right adrenal mass. Again, it's not uncommon to see, like, especially I deal with residents. I sign their preliminary reports, so I know where are the misses look. Usually, what they usually don't look at. So one of them is the adrenal masses, intrathoracic or pulmonary mass, lung masses or lung lesions, because they were just focused on the spine. Psoas hematoma or lumbar hematoma. Sometimes you just have a lumbar spine looking for something happening in the lumbar canal or like something acute happening, and we forget to look outside the spine for maybe hematoma that can be easy to miss. Here we see widening of the facet joint at L4-5. Here we see that chip fracture of the occipital condyle here that is not easy to see on the axial, but on the coronal, it is easier to detect. For the head trauma, important points in the axial runs. As we look at looking for subdural hemorrhage, like everybody should be aware that there is a subdural window. So when you click that subdural window, it makes it appropriate be able to see the subtle difference between the brain parenchyma and the slightly hyperdense, maybe thin line of subdural or epidural hemorrhage that is sometimes too dense, and you might not be able to discriminate from the adjacent calvareal bone density. So specifically considering this subdural window is important. So we have to learn how to optimize this window and recognize, again, learn to recognize the effaced basal cisterns, as again, we all have tendency to, when we see like younger patient, we know like younger patients, still the brain is not atrophied. So if we see a slit-like ventricles, it's fine. But sometimes if the basal cisterns are effaced or partially effaced, it can raise a concern of something happening. You need to learn how to recognize effaced basal cistern, recognize uncal herniation or uncal medialization, fractures through the skull base, most important, and through the carotid canal specifically, and sometimes we might order a CT angiogram. Here we see the importance of the windowing. As you see here, this is the subdural window, and it shows the dense subdural lift convexity subdural hemorrhage. And maybe here it's kind of like blending with the bone, so might not be able to actually recognize it, specifically if you are like maybe a general radiologist or not, or like junior resident or something like that. So you might not be able to see that hemorrhage unless you do the windowing, the appropriate windowing. And here, this is the magnified view, just to show the difference. And here, this is isodense subdural hemorrhage, and it's easy definitely to miss if it's just isodense to the brain parenchyma. Again, you should consider like how to find it and to expect it. Maybe if you don't see the undulations of the sulci, you should raise a concern of something happening here. Importance of the coronary formats. Again, the tentorial subdural hematoma, specifically if it's minimal. Inferior frontal parenchymal hemorrhage also can be easier to see in the especially in the midline, near the midline, like parafalcine frontal lobes. If sometimes with the as you scroll in the axial images with the high density of the surrounding bone near the anterior cranial fossa skull base, and you see like this streak artifact may make you have like tendency not to look carefully for intraparenchymal hemorrhage. So doing the coronary formats can help finding this. Definitely the bone fracture, if the fracture line is parallel to the axial plane, then coronal can help. Superior sagittal sinus, transverse sinus thrombosis, and intraorbital hematoma, sometimes scrolling through the coronal and look at the orbits, even though it's just a head CT, may help to find a small hematoma or like maybe an intraorbital mass. Fracture lamina peperiscia, fracture occipital condyle. Here is an example of minimal subdural hemorrhage along the right tentorium, which can be easy to miss in the axial plane. Again, there is extraaxial hemorrhage here, easier to see in the coronal and maybe sagittal, but not easy to see in the axial. Here, a little bit of this hemorrhage. Again, the sella in the sagittal head. Sometimes you may have like patient have headache, CT is negative, but the only finding is just like pituitary hemorrhage, and the only way to see it or to be able to see it, sagittal. Fracturing the clivus, retroclival hemorrhage, orbital roof, cerebellar tonsil herniation, brainstem sagging. All these can be just with a couple of sagittal runs, like maybe three cuts or 4 cuts will solve it. So again, while you're doing your search pattern, just consider these potential findings easy to see in which direction. If we move to stroke imaging, there is some important points. You should do every effort in windowing to see or to make the contrast or to change the contrast to be able to see the subtle hypodensity of the cortex or any cortical based hypodensity, triangular shape. That's very important to like teach your eyes what is the optimal window to increase that contrast to see it. Easy to miss portions in the brain and in the for stroke, upper axial, in evaluation for small infarcts, perirelandic regions. Scrutinize the occipital lobes because there is tendency to ignore the subtle differences between when there is a subtle infarction because of the density of the bone in this area. Coronal and sagittal in evaluation of the cortical-based infarct, especially in patients with a small vessel disease, because patients already with a small vessel disease, there is brain parenchymal hypodensities everywhere, but what we're looking for is triangular shaped cortical-based infarction. Use the thin sections to look for dense artery sign. If the study is degraded by motion, you should mention that in your report because it would let the clinician know that it is not the best exam. So if there is a potential stroke, at least you are off the hook. They know that you did your best, but this is not the best exam. CT angiogram, you should have a plan because most people in CT angiograms, they consider CT angiograms as just look at the vessels in axial run. That's it. That's CT angiogram, but this is wrong. CT angiograms, usually we do it in the United States. Most of the time, it's a head and neck angiogram, starting from the arch of the aorta up to the vertex. And when we do that, definitely then the head and neck don't have only vessels. There are other structures. So you need to make sure that you don't miss other structures or other structural abnormalities. There is a big list of things that can be missed in the CT angiogram if you just focus on the angiogram. And make sure to look at all the vessels in all planes. Sometimes your protocol of imaging need to be optimized just to be able to have a general look of like how the vasculature overall look like. Maybe you need the MIPS, maybe you need the 3D MIPS, just to have an overview of the vessels, the vasculature, because that sometimes would give you a better idea of maybe an aneurysm, maybe like asymmetry in the vascular diameter, maybe it's smaller on one side, maybe there's like occluded upper branch or lower branch of MCA or M2 that may not be able to find if you just scroll the axials. So make sure that you do thick slabs, sagittals, coronals, and axials, and then look at the thin axials. M1 occlusions best seen on coronary format, M2 and M3 branching best seen on the sagittal thick slab. Corona siphon should be evaluated in coronal and sagittal thin cuts because of the small aneurysms. A2 occlusion best evaluated in coronal and sagittal actually. All angios should be evaluated for arteriovenous malformation, which means that you need to look outside the expected course of the distal intracranial vessels because AVMs can happen anywhere. So you need to make sure that if it's small, you don't miss it. The looping course of the distal cervical vertebral arteries and ICAs in the coronal and sagittals for aneurysms. That's very important. Here's an example of subtle loss of insular ribbon. If you do proper windowing and make the contrast high, then be able to see like the left MCA territory infarction, that it may be subtle in the regular brain window. Here, again, occipital lobe infarction. So when you look at the sagittal, you can better see that hypodensity compared to looking at the axial. So that's important to make sure that sometimes some CT scanners can falsely give you hypodensity. Can falsely give you hypodensity in the occipital region. So you need to make sure to know like if this specific scanner does that or not. But here it's very delineated, very demarcated, which means it's not that recent of infarction. Again, windowing. So if you do the windowing here, this is a patient, like old patient with white matter disease because of like small vessel disease. But here we have more than that. We have a larger area of cortical-based hypodensity that is easy to miss if you don't do a proper windowing. So this is CT showing this hypodensity, DWI showing diffusion restriction, and if you run the thins, you'll be able to see the dense artery sign that the resident actually didn't see because they didn't look at the thins. They just looked quickly at the thick slabs or thick cuts and was not able to see this. So basically, the resident didn't do proper windowing and didn't do the thins. So he missed that infarction. Okay, so it's very important to know where are the misses. Again, here, plain CT potential blind spot is the superior ophthalmic vein asymmetrical prominence, which raised the concern of CC fistula. Again, this patient had, I think, headache, proptosis, and CT brain was negative, but the only finding was just this asymmetrical prominence of that superior ophthalmic vein, which based on this, I suggested CTA, and it showed that the right ICA communicates directly with the cavernous sinus, resulting in large volume arteriovenous shunt. Sometimes you might not be able to see it, but at least you can see the secondary signs of the CC fistula. Such type of fistula may either occur after trauma or may spontaneously develop after rupture of an aneurysm, pseudoaneurysm located in the cavernous portion of the ICA. I have a story actually of a patient who had trauma, and there was a tiny pseudoaneurysm after that trauma that was ignored or not seen in the cavernous ICA, and this tiny pseudoaneurysm, the best action was should have the patient should have been followed up in 2 weeks or 3 weeks just to see if this pseudoaneurysm changed, because otherwise what happened is the patient came back after I think 3 weeks with that pseudoaneurysm increased in size, created a fistula, caused CC fistula. So make sure after trauma to look at the bone and to look at the cavernous ICA for pseudoaneurysm or sometimes dissection. I have a case of, again, patient had surgery, sinus surgery, and the surgeon actually hit the cavernous ICA, and that caused what is happening here? I don't know what. Okay, and that caused some intramural hematoma because the surgeon hit that cavernous ICA, and that led to stroke, like showers of like infarct in the that side. And then again, the resident read the CT angio, and because I did the comparison, direct comparison of that CT angio, and I said I saw a little halo of soft tissue surrounding that cavernous ICA that was not there 2 weeks ago, raising the concern of intramural hematoma or potential small dissection at this carotid siphon, probably caused by this type of surgery. So just make sure that you look carefully. That's important. Here's if you see there is right M1 occlusion. Again, this was missed by the resident because it's not occlusion, it's a filling defect, not completely filling the artery. So and when you do the axial run, sometimes you may not be able to pick it because of the tortuosity of the artery. So it's good to just look at the thick slabs in coronal, just to make sure that the thick slabs will give you the like thicker collection of slices that make you like see confidently the artery here on the left is doing well, the artery on the right is gone, or like partial filling defect causing severe stenosis, severe focal stenosis. Okay, again, this case, headache, vague symptoms. The only finding was to look carefully at the cerebellum. There is infarction, subtle hypodensity in the right cerebellar hemisphere. That was confirmed after that with this MRI diffusion restriction. And again, be careful because cerebellar infarction may have very vague symptoms. So look carefully for hypodensities, specifically, and if there is, because there is tendency to ignore the cerebellum, basically because many of the CTs have the posterior fossa structures limited evaluation because of the streak artifacts from the dense bone in of the petrous and the occipital bones. Here, this patient was outside hospital referral. We see this was missed. basically there is a thrombus in the transverse sinus. This was, I think, pregnant, and they did a CT. There is nothing, and then they did MRI without contrast, and they didn't do venogram. There is this hyper intensity on T1, suggestive of thrombus or partial thrombus. And the patient actually, this is still the same setting. They thought the patient has press because of this like abnormal like diffusion restriction in the left temporal lobe, which is not characteristic of press usually. But they thought like, okay, this probably she has preeclampsia or something, and this is probably press. But actually, this is venous infarction. And then the patient came 4 days later to our institution showing venous hemorrhagic, well-established venous hemorrhagic infarction. But the thing, it was missed at the first sitting because the person who looked at the CT run it very fast, didn't look carefully, like, okay, pregnant with headache, look carefully for the venous sinuses. This story, actually, this is a young patient, 26-year-old female with some stroke signs, vague stroke signs, like paresthesias and weaknesses. And then a resident who read this looked at the periventricular and deep white matter hypodensity, said like likely small vessel disease. But the patient, remember, patient is young. Small vessel disease can happen in the older ages. So I asked them to bring the patient back to do MRI because this is white matter disease, basically. So this was multiple sclerosis acute phase, or like active plaques which show enhancement, T2 hyperintensity, that just make sure that, like young patient, most of the time they don't get, if there is like periventricular and deep white matter hypodensity, this is unusual. You need to think something else other than all the brain. Again, another potential miss is looking at this area of like very variable anatomy. Maybe you would think like this is like a retention cyst in the sphenoid sinus, but this doesn't look like it. You need to raise the concern of like there is round the calcification, mass-like thing. It is actually an aneurysm. But again, our eyes have tendency to ignore the things that are very variable. It's here, this area is very variable. Some people have like very big sphenoid sinus, and some of it like occluded because of a mucocele or something, but usually mucoceles don't have this like very nice rim of calcification sometimes, but you need to raise the concern. Just make sure, be careful of like calcified aneurysm in this area can be mixed up with something else. Again, this is a patient with headache, and although this is a CT, but still like plain CT, non-contrast CT, but there is a mass-like lesion here that is actually an aneurysm. Okay, so this is, yeah, this is another aneurysm basically. So again, always look at the thin sections. So I did this case, and there is the expected location of anterior communicating artery. There is a prominence of that area. There is something mass-like here. And I did reformats because what we get, the reformats we get is thick slabs. I did the thin slab reformat. We have in the PACS system, some PACS system are well equipped with this feature basically. So I did the sagittal reformat, and there's like a mass-like thing in the middle of nowhere. It's not part of the brain, or not part of the nothing. It's just by itself. So based on this, I suggested there is probably an anterior communicating artery aneurysm, and they did the angiogram, and there's this chunk of aneurysm here. This is actually CT. It was a CT neck, and I looked at this, and Usually when you do as when you look at the CT neck, most of the time they're looking for something in the neck. But unfortunately, they have to include something of the brain. So when they look at when they include that thing from the brain, you need to make sure that you don't miss it. Sometimes I have actually a resident, a very brilliant resident who was looking for a neck study for a like 5-year-old kid, and she picked up a medulloblastoma in the cerebellum. So just make sure, look at the edge of the scrolls, like the upper aspect, lower aspect, the easy to miss areas. I usually start with them. So there is a left pike aneurysm here. Uh, and here there is partially included avian. Here there is an bone metastatic lesion. This was a CT neck, and most of the time when we do a CT neck, we look at the soft tissue. We don't specifically intellectually do the bone window to just have a quick look on the bone appearance. So this is a bone sclerotic lesion, basically. This was actually again a neck CT scan, follow-ups for many times, but the missed thing was this basal artery pseudoaneurysm. In like 3-4 CT necks, it was not seen. So just to remind you where to look, what to look for in these specific situations. Again, this is a CT neck. They were doing, I think it was a CT angio actually. So they were looking for something, and then there is a mass in the fourth ventricle that can be only seen and easier to see if you do a proper windowing and look at the sagittal view. So here there is this patient was getting treated of, I think, lymphoma, and this is before and this is after. This is 3 months prior. And the difference here is like this tumor is now ulceration. Okay, so the patient improved everywhere, but there is ulceration here and the bone erosion actually that you can only see or better see if you do the sagittal. Okay, we are all thinking of like, okay, there is hemorrhage here, measure so and so, but there is actually an encephalocele here. It's not a very important finding, but it's just something you may need to consider. Sometimes you can have an encephalocele and seizures because of something like this. And then another encephalocele in the sigmoid sinus. Another subependymoma, as you see here. This is not normal. This is a mass. This is the MRI. Subependymoma shows T2 flare and T2 slight hyperintensity, brighter than the brain. Patient 70-year-old with headache showing left MCA aneurysm. So we can use the shrinking brain CSF, surrounding CSF as a contrast media to see, to look for aneurysms. And here, again, suprasellar cistern, mass-like lesion in the confinement of the carotid terminus. I suggested an aneurysm, calcified aneurysm, partial calcified aneurysm. I ordered CT angio. Here, this patient has headache and there is a little hyperdensity here. that was not hemorrhage, it was AVM. But I mean, AVM and hemorrhage, like look for subtle hyperdensities. Sometimes you'll be able to see like vascular structure that is not in the expected location, might raise the concern of arteriovenous shunting. This patient, renal cell carcinoma with headache, came to the emergency room. Resident looked at the CT, small vessel disease, normal, go home. Again, looking at the study, I called the emergency room again. I said there is hyperdensity in the right superior frontal gyrus and surrounding edema. Looked at the history. The patient has history of renal cell carcinoma. This is probably a true finding. I called them back to ask them to call the patient back to do more investigations. Patient has tinnitus here, and there is glomus jugulare. Just make sure don't miss this because this is easy to miss finding. There is glomus tumor here. Anybody want to take this study, this case, this single shot? It's an interactive, so somebody should talk.
Aberrant internal carotid artery on right side.
Yes, left side. This is absent. Internal carotid artery absent on the left side. That's correct. Good job. So it is easy, very easy to miss. Like this was like the fourth or the fifth CT at our institution, and nobody detected that. I would miss it. Everybody can miss it. It just was luck, pure luck that I was able to see it. But it's very easy. We don't pay attention to every single structure. If you have a big list, 70 cases looking for strokes or traumas, or you are in a big hospital having like tons of normal cases, and a patient is not complaining of just trauma, but nothing. You didn't see bleed, you didn't see fracture. Let go. But yeah, it's an easy to miss finding. Anybody would like to look at this, to take this one? Okay, so this is a trauma case and the patient is unconscious. The lens is fallen. The left lens is fallen. Again, another easy to miss. If the patient is not able to talk about it and they can't see, but they are actually loss of consciousness, they can't tell. Okay. Okay, another potential blind spot is looking at the soft tissue. If we're looking at the brain CT scan, we focus on the brain and bones, but we should also look outside the brain. There is left parotid mass here. There is a clival lesion here, which you can see better if you have bone window on the sagittal view. I know most of us would not do that, but it's just good to maybe considering this. So there is the clival lesion here. Anybody would like to take this case? Okay, so
Clivalytic lesion.
yes, clivalytic lesion, that's correct. What could it be? What is the differential here?
Metastasis.
Chordoma. Chordoma.
Benign looking.
Go ahead.
Benign look, yes, it's regular. continue cortical.
Yes, that's true.
It's A2.
Okay. Let me know if you have other.
A2.
Mhm. So it's an expansile lesion. As you said, the cortex is good. And this is usually fibrous dysplasia of the clivus. It's a leave me alone lesion that maybe if you have an MRI, it'd be scary because it looks scary on the MRI. But if you see expansile lesion in the clivus, cortex is fine, central hyperdensity or central like cystic-like lesion, most of the time this is fibrous dysplasia. Fibrous dysplasia everywhere else, it has uh, uh, ground glass matrix, but here in the clivus, it has characteristically this appearance. Okay. So this is an osseous metastatic disease in the clivus. As you see, this is erosive lytic lesion of the clivus with loss of cortex. Retroclival hematoma sometimes sagittal would help in seeing this. This case was a CT neck, and the image on the right is 1 year ago, and the image on the left is now. Anybody would like to share thoughts? Okay, so there is thickening and enhancement in the left glossotonsillar sulcus. Again, another easy to miss finding. Anybody? This is a CT neck. And
It's just the kind of thrombosis.
yes, that's correct. Good job. This is all thrombosed, and there's like a little bit of frame of enhancement of the wall of maybe recanalization, minimal recanalization. Importance of looking for abnormalities or masses in the retromolar trigone. It's another easy to miss finding or location in the CT neck. So you need to make sure that in this area, there is no mass. Okay, so in the CT, because of, again, oral lesions are potential areas of overlooking because basically the dental amalgam or dental work have extensive streak artifact most of the time that makes you automatically put in the disclaimer in the report that, okay, the dental amalgam limit evaluation of the surrounding structures and don't look. That's wrong. That's wrong. I'm trying to say, okay, say it, but look, because sometimes you might miss something. And this is even with the streak artifact, it's visible. So it's like you can see it. So again, when you have a disclaimer of like you think that you are off the hook, like because you're saying this is like streak artifact limit evaluation, or the study is limited by motion, or the study is limited by so and so. But there is a finding you still can see. That's important to look, because if you miss it, first you will harm the patient. Second, it might be a lawsuit against you. Okay, so this is a diagram of like the site of the retromolar trigone and the spread of tumors in there. Okay, so it is important to consider the comparing sagittal thick slabs to sagittal thick slabs of the CT angio in cases that you have a study who have like patient has intracranial bleed or subarachnoid hemorrhage, and the patient is in the hospital and started or they are repeating the CT angio after 2 weeks or 1 week or 10 days because the patient is developing new symptoms. So make sure that there is no vasospasm. And the best way to do that is if there is mild or minimal vasospasm, you need to look apple to the most recent one. And to do that, you need a thick slab here, a thick slab there, and like pair them together just to get the best out of what you have. Patient has history of tooth extraction. Anybody would like to take this case?
Thrombosis. Internal jugular vein in left side.
Yes, that's correct. And what else?
Abscess formation.
Abscess or cellulitis.
Ledwick angina.
Say it again.
Emphysema.
Yes, there is air. There is air in the soft tissue. This could be an abscess or could be surgical emphysema or emphysema from the recent procedure. Plus the inflammatory changes, plus this flow density that like in the
Sublingual state.
sublingual region.
Post-operative, there is skin injury in left side.
Yes, that's correct. So the lesson from this, if you have an abscess in the neck, just look carefully, or like any inflammation in the neck, look carefully. The first thing for
Thrombosis.
thrombosis. That's correct.
Lamar.
Yeah, Lemire syndrome. So this is talking about Lemire syndrome. It refers to thrombophlebitis of the internal jugular vein with distant metastatic sepsis into the of the infection into the
Mediastinum.
Yeah.
In the cervical lines and mediastinum.
Yeah, that's correct. Next.
EVM مش EVM cavernous
Cavernoma.
cavernoma
It can be cavernoma. What else?
fistula or fistula.
Venous thrombosis. Hemorrhagic venous thrombosis could be.
It was actually an aneurysm. And in this case, yeah,
M2.
This is right, M2 aneurysm. The trick here in this case that there was a thrombosis or like embolus of the right M1. So when they did a CT angio, the aneurysm was not seen because the thrombosis is proximal to that. Okay, so the only way to see this aneurysm was MRI. Okay, so this was actually our case, and it was published 3-4 years ago, of the importance of like maybe looking carefully, even though you have a CT angiogram, you still need to look at the MRI. Maybe you can miss something like this. It's very rare, definitely. How about this one?
Aneurysm at left M2.
Yes,
MCA.
that's true. That's correct.
Small carotid, small tubular carotid.
lesion related للليفت aspect المانديبولار body.
Say it again.
Left carotid. And it-
lesion malignant looking lesion related للليفت aspect المانديبولار body.
Yes, that's true. And also this abnormal enhancement as well.
Yes. Extension
Which can be seen here.
soft.
Okay. Oh, this is a left floor of the mouse, man. And one important thing, actually, sometimes if you have an MRI to evaluate this, the best way is to look at the coronal T1, because coronal T1 will give you a good normal contrast with the fat. So if you see, look here, look at this mass. See the difference? So the fat here is preserved, there is a mass. So the only way to see it is to look at the coronal T1 is the best way actually to see it.
Coronal T1 fat cell.
No,
Post
not fat.
enhancing.
Coronal T1, just regular coronal T1 or T1. Sometimes you need that T1 with not fat sat or not fat saturation, just to see the fat, the bright fat compared to abnormal tissue. And you might need this in the skull base, in the pterygopalatine fossa, in many actually applications. In maybe sometimes you need to look at the if you have like foramen valley involvement, sometimes you need to use the fat as a contrast. So just regular T1.
Okay.
Pre-contrast, not non-contrast. And this is the tongue lesion on the CT. It's definitely much better.
Left lower mouth mass in CT.
It's the same case. So if you look here,
Same case.
yes, the mass is here, but on T1, it's better detected. Okay?
It's better seen. Yes.
Yeah.
Okay.
And this is the same case axial. Okay, potential angiogram blind spots again. In this case, as I mentioned before, the coronal can help in looking at the M1, M2, M1, M2 lesions. In this case, actually, the patient had filling defect on the left M1 and in the right M1, bilateral in the same time.
Stenosis.
Filling defect, actually, not stenosis. This is filling defect. Here, filling defect. And in this patient, there is pulmonary embolus. Like patient has dizziness, diaphoresis, and came for angiogram. Everything in the angiogram is fine, but just look at the lower portions, lower cuts of the angiogram. You might be able to detect pulmonary embolism. Okay. Here, this case was like stroke, and everything was called like everything is patent stroke, but like small emboli not seen on the angiogram. But the only thing is just the source. This was missed because we have tendency not to look at the arch or like say what we see in the arch when we do CT angiogram. So this is an thrombus in the arch of the aorta, which is the source of the emboli or thrombi. MRI brain evaluation, important points. Each sequence should be used for evaluation of common findings and easy to be overlooked. Findings, examples, loss of flow voids. Again, not uncommon to overlook loss of flow void in the ICA. Like patient, in many cases, the internal carotid artery chronic occlusion, the brain is fine, the brain looks fine, maybe some small vessel disease, but actually the ICA is occluded, and you can miss it on MRI T2 by not looking at the ICAs specifically to see if there is loss of flow void or not. Again, AVM or dural AV fistulas, again, T2 is the best. Brainstem lesions, T2 is better than the flare. Abnormal temporal bone findings such as dilated vestibular aqueducts. Diffusion weighted images, usually we use the diffusion weighted images just to look for strokes, but there are other important findings you might be able to detect on DWI, such as brainstem strokes. And the brainstem, the problem with the brainstem strokes is like the lesion is too small, and clinically the patient has a big thing. So be careful when look carefully for brainstem DWI lesions. Calvarian metastasis, lymphocytic hypophysitis, you might not be able to see on the DWI, like thickened infundibulum, cholesteatoma, epidermoid, diffuse axonal injury, starry sky fat embolism, bilateral symmetrical cortical diffusion restriction in hypoxic injury, which can be subtle. Important point in T1, again, internal carotid artery dissection, the crescent sign in the skull base region, easy to miss.
Please, the two ones before this picture. Les deux derniers, l'avant, before this, before the diffusion, the T2. Yes. Thank you. Loss of flow voids, ABM. Thank you.
Okay. Again, important T1, ICA dissection, skull base, bright bilateral basal ganglia in liver disease. In T1, unilateral basal ganglia in non-ketotic hyperglycemic chorea can be bright. Sagittal T1, transverse sinus thrombosis, mid-sagittal clivus. You can use the mid-sagittal T1 in looking at tons of things in just one look. By just starting, most of the protocols start with the sagittal T1. So if you look at the mid-sagittal T1, you can be able to see clival lesions, metastatic calvarial disease, cerebellar tonsil herniation, pituitary lesion, infundibular region, and the brainstem sagging. Again, here, potential MRI brain blind spots. Again, this is the crescent sign here, dissection of the left ICA. And this patient had rickettsia, which is an infectious disease that we see in America in the north. And the patient has, like, the residents looked at this. This is a 13-year-old female. Everything is fine, but the thing is, there is bilateral symmetrical enhancing cranial nerves that can be easy to miss because they are bilateral and symmetrical. And we have that tendency to ignore the things that looks like each other, especially when you look at the brain. We usually have like focus on the things that is odd, like unilateral. So just put in mind that this might be a miss. This patient, CT, I think it's CT neck, and there is an AVM or arteriovenous shunting here on the CT neck that is suggestive of something happening. This actually on the MRI is how it looks in the MRI. Again, I'm showing this because T2 can show this kind of abnormality, but just you need to be ready or like make sure that don't miss it, expecting it. Okay. This is a 31-year-old male with seizures, MRI protocol, epilepsy protocol showing prominent tortuous venous or like vessels everywhere. So it is some sort of shunting, but it's just general. Okay. This is the case we presented earlier. And I think this is probably the last slide. And this case is a meningitis. So leptomeningitis, actually, if you see, look at the ependymal wall showing enhancement, and also the surface here of the brainstem. This was meningitis. Okay, that's it. Thank you for listening.
Thank you so much.
Okay. Okay, this concludes the lecture, and thank you for attending this. And we'll have more lectures in the future, inshallah.
Thank you for all.
شكرا جزيلا دكتور عبد المحسن. دكتور عبد المحسن. شكرا جزيلا لكم يا شباب، شكرا لكم، إن شاء الله نقابلكم الجمعة الجاية إن شاء الله. السلام عليكم
إن شاء الله. عليكم السلام ورحمة الله. جزاكم الله خيرا دكتور.
الله يكرمك، الله يخليك.